Good evening, Shivani and Dr. Sunil, and thank you very much for a very kind introduction. And thanks for everyone who's really, taken the time out to join on this Saturday evening. Let me just share my screen. Give me a moment. Shivani, is all good?
Yes. You're audible and everything is visible.
So in which case, I'm going to dive into the topic straight. It's going to be what is now being called a significant amount of clinical radiology. So when we talk about connective tissue disorders or vasculitis, so obviously there will be a lot of clinical background associated with the talk. What we will do is that I will run through the basic theory part of the imaging and clinical first, and then we go through a few challenging cases. So whenever this goes in record mode, it starts to not scroll many times, Shivani. So give me a moment. I think it will scroll for the on-site.
Amit, are you there? Is it?
Because when we tested it, it tested, but I've seen this with a lot of the softwares that when they go into the live mode and they start to transmit, the slides don't change.
Oh, is that so? So we
I was last time told to use the controls which come on the left-hand side at the bottom of the screen rather than the desktop, which so are not coming now.
We'll just try it. Like I'll stop the sharing. Can you share it again? Then it'll work.
Yeah, it happened with the webinar I did last week also, and then I had to use the controls which were no.
Just move the slides. Let's see.
No, they're not moving.
The arrow key is also not working.
I'm looking for the arrow key at the bottom of the left, but it's not coming. I'm trying
on your keypad, ma'am. The arrow key is on your keypad.
No, arrow key on keypad is not working. That's what is not working. Yeah, now, okay. Yeah, okay. Sorry for that. This always happens. We test it just before we go live, and then when it goes into this mode, okay. So to first understand what is vasculitis, as the term is self-explanatory, it's an inflammation of the vessel wall, but then why are we calling it pulmonary vasculitis? So is when there is inflammation of the pulmonary wall or vascular walls elsewhere in the body, does it mean that you will only see it as an inflammation of the wall, which means that thickening of the walls, enhancement? So unfortunately, the clinical manifestations as well as the imaging manifestations are not that straightforward. And why that happens, we will see as we go along and understand the topic. So when this inflammation is very necrotizing, you will see with some of the vasculitis terms being used, granulomatous, necrotizing. So these will eventually lead to destruction of the walls. Any vasculitis mostly is an autoimmune phenomenon, other causes being such as infective vasculitis. So they are understandably multi-system disorders. But having said that, every vasculitis does not involve the same set of systems and does not have the same set of manifestations. So the thing is to understand that what governs that what organ systems are going to be involved and how they are going to manifest is essentially which size of the vessel is involved. So the last classification that we have is of the 2012 Chapel Hill Consensus Conference classification, and still the same classification system is in place, which essentially divides it into these 7 classes that you can see, and which is based on the size of the vessel involved. And then I'll come to how it affects the organs. So we have large vessel, medium vessel, small vessel. Variable vessel means it can involve small as well as large vessels. Then the other 2 categories also say that vasculitis associated with systemic disorders means that a medium vessel or small vessel vasculitis is also involving multiple systems. But here the predominant problem is the vasculitis. But in those which are associated with systemic disorders means that we have a systemic disorder which is predominant, mostly autoimmune disorders like lupus, rheumatoid, and sarcoid, and vasculitis can be a component of these. And then there are those in which we don't know what the etiology is, like Hep C associated, Hep B associated, infection associated, drug associated vasculitis. So altogether, there are 7 categories which have been given. So every time which I stop, which means that this is not transitioning. Just one second. Okay. Now, from this diagram, the same thing is illustrated, that if you go from the aorta right up to the capillaries, you have large vessels. The poster boy of large vessel arteritis is basically Takayasu arteritis and giant cell arteritis. We have medium vessel involvement such as Pan, Kawasaki disease. And then we come to this large group, which is going to be our main point of discussion, which is small vessel vasculitis. If you look at the small vessel vasculitis, the 2 broad categories that we enter are ANCA associated and those which are immune complex associated. So one is that it is mediated through ANCA, and the other is that it is through deposition of immune complexes. Those are the 2 main categories. Now, how does this play out in terms of imaging manifestations and clinical manifestations? So if you have large vessel vasculitis, they are going to understandably involve the big vessels, which are not only aorta. See, there are many vessels which are big, like renal arteries, but the vasculitis does have a propensity to involve some of these, like in large vessel vasculitis, apart from aorta, in Takayasu's, subclavian can be involved, renal can be involved. And if it's a GCA, we can have more of cerebral involvement, means extracranial carotid artery branches like temporal, ophthalmic, mesenteric. So these are the manifestations of large vessel. What happens in case of medium vessel vasculitis? Here, the branches of aorta come into play. We were on Kawasaki, we were on Pan. So the branches of aorta come into play, which is celiac, mesentery. So we have more of visceral manifestations. Coronary arteries also come into play. And an interesting manifestation is that there are, necrotic ulcers, nail-fold involvement, and mononeuritis multiplex. How does it come into small pulmonary arteries? What if pulmonary artery branches are involved? Then you can get mass-like lesions or focal lesions. Head and neck involvement gives rise to epistaxis, sinusitis. So this group is basically Pan and Kawasaki. When we come to the small vessels, it has a characteristic triad where the hit is taken by 3 organ systems, which is skin, kidney, and lung. So this is the main group that we will be talking about today. And the triad that you get is skin, kidney, and capillaries. So when pulmonary capillaries are affected, that's when patient presents with hemoptysis, you get DH, and all these individual types as they play out, we will discuss as we go along how to differentiate amongst the LVV, MVV, SVV, and among the SVV, how on the basis of imaging you can differentiate amongst the various categories. So today I will focus on the lung involvement part of this vasculitis. So if we look at the lung involvement, I already mentioned that the small vessel vasculitis is the most common group. We have 2, ANCA and immune complex SVV. Immune complex SVV is anti-GBM disease, or earlier known as good pasture syndrome. Basically, this has one entity which is of interest to us, which is pasture syndrome. And in ANCA associated, we have GPA, earlier called Wegener's, we have MPA, microscopic polyangiitis, and we have EGPA, 3 main entities, earlier called Churg-Strauss. So 3 main entities in ANCA associated vasculitis and 1 main entity in immune complex SVV, which is anti-GBM disease, earlier known as good pasture. And then we have other vasculitis which involve the lung quite commonly, like SLE, rheumatoid arthritis, and Behçet disease. So now we come to what is meant by, when I meant lung involvement, it actually means that this SVV group involves the respiratory tract. The respiratory tract includes not only the lung, but also paranasal sinuses and temporal bone, basically. So these people will come with manifestations which involve the sinonasal cavity and also involve the temporal bone. In the lower airway, you can have involvement of lung parenchyma. Whenever the capillaries get involved, small vessels will involve the airway and will directly involve the vessels themselves. So if you get capillaritis, it will result in DAH. If you get necrosis, if you get involvement of slightly bigger vessels, you will get an overt necrosis of the lung parenchyma, and then you will get nodules, mass-like lesions. And this is also associated with a lot of inflammatory cell infiltration. In the airway, we always get inflammation, and eventually you will get stenosis. So how we will discuss this is that you can have DAH, you can have focal lung opacity, central airway involvement, peripheral airway involvement, and direct vessel involvement. And there are other manifestations which are less common, which means you can have ILD also associated with vasculitis. It's known as vasculitis ILD. This is the correct way to write it, vasculitis ILD, which means ILD in SLE. And there is also, coexistence of IPF and AVB reported is referred to as vasculitis ILD. Bronchiectasis is also a consequence of repeated airway inflammation and occasionally pleural effusion. Now we come to the first manifestation. What if you encounter DAH on imaging? What next? And of course, how do you diagnose DAH from the other causes of extensive acute bilateral ground glass opacity? So, whenever we are confronted with bilateral diffuse ground glass opacities, differentiation between fluid overload, permeability, edema, ARDS is like another talk, and I think I've done it also a few times. But basically, whenever we are getting an acute onset whiteout lung, we are looking out to differentiate amongst all these entities, which is fluid overload, permeability, edema, ARDS, and infections. So the characteristic words which are used in context of reaching the diagnosis of a DAH are lobular appearance. The distribution, is not exactly giving an apicobasal gradient, but it does tend to have a more involvement of the dependent lung. Within a few days, within 2 to 3 days, the septal thickening starts to come and gives it a crazy paving appearance. And although the characteristic description of DAH is that it comes and goes fast, but recurrent episodes will eventually result in fibrosis and interstitial thickening. So the other one important sign, so this is, you can see in the same patient, there are like different ages of the DAH. So this lobular appearance, and what is interesting in this lobular appearance is it's like a inverse photocopy of, like we say, thickening of the interlobular septum in IPF or in fluid overload. Here reverse happens, which means that while rest of the lung is looking black, if you look at the interlobular septum, this polygonal structure, interlobular septum is looking black, which means that this is normal while this has hemorrhage in it. And why does this appear black? Because once the DAH starts to clear out, it clears out through the veins, and because the veins run in the interlobular septum, these are the areas which clean out the fastest. Yeah, these are like the highways of the lung which are cleaning all the muck away. So this cleans it out the fastest. So that is why there is a relative clear margin, which is because of the clean interlobular septae, and you get this lobular appearance. And another part of the lung adjoining the fissure, which is giving a crazy paving appearance. A slight epicoblasal gradient you can see, not as overt as you would get in an ARDS. So this is like different ages of the DAH you can see in the same image, and eventually it will lead to some interstitial fibrosis. Now it's very interesting, the same way that we have been classifying vasculitis, now we are talking about approach to DAH. So DAH is broadly classified into 2 groups, some would say 3 groups. The 2 groups are with capillaritis and without capillaritis. Without capillaritis is also known as a bland DAH. So with capillaritis means that it is a vasculitis associated DAH. Without capillaritis means like it can happen due to anticoagulation syndromes. It can be a part of antiphospholipid syndrome. And when we have ARDS or we have any rapid exudation into the lung, there can be a component of hemorrhage also. So some texts would classify this as DH without associated capillaritis, and some would create a third category of DH associated with hyaline membrane. So whenever there is a hyaline membrane formation, there is an exudation, you can have some amount of hemorrhage. So this is the classification of DH, and that is how whenever on imaging, plus you are aware the characteristic clinical manifestations of hemoptysis in up to 60% of the patients, drop in hemoglobin, rapid clearance, all that is supportive. You set out to look for a cause. In the cause, the first thing we ask is that what is the status of the skin and what is the status of the kidney. So we always, the simplest test before, in several hospitals, including my hospital, the ANCA takes a while to come back. Like it's not a same day report, and at least we don't get an ANCA same day report. But what you can get the same day, even if your patient doesn't have skin lesions, is the urinary sediment. So what are we looking at? That so we always ask when reporting the CT that if you're looking for the cause, that does the patient have an active urinary sediment, which means that can you see microscopic proteinuria? Can you see RBCs in the urine? If we have that, which means that it takes us towards a small vessel vasculitis. Now, when we come to ANCA-associated vasculitis, I just underlined a couple of keywords which differentiate the two major entities in this group, which is GPA, vaginous granulomatosis, from MPA, which is microscopic polyangiitis. Both have capillaritis. This has granulomatous inflammation. Okay, so that's why it's called ANCA-associated granulomatous vasculitis, while this one doesn't have. The type of ANCA, C ANCA, P ANCA, the type of ANCA which is associated with the two is different. So GPA is associated with C ANCA, the correct term for which is PR3. So PR3 ANCA presence implies GPA, while an MPO ANCA presence implies microscopic polyangiitis. So it's known as a PR3 vasculitis or an MPO vasculitis. So these are the two main SVVs in this category. Anti-GBM disease, I already told you that there are autoimmune complex deposition, if you remember from MBBS teaching, in the glomerular membranes in the kidney. So similarly, in the lung also there is immune complex deposition. And you can pick this up in a kidney biopsy. You can, but initially, a serum test is done, and you can pick up immune complex disease on the serum testing also. And these are the other causes of DH which are enlisted. And I already brought out that hyaline membrane forming and a consistent type of pulmonary venous hypertension, like you get in patients with mitral stenosis, will also give rise to what is called as bland hemorrhage. And bland hemorrhage may be further subclassified into two types: hyaline membrane associated and not associated with hyaline membrane. So that much for DH. We will come back to DH once more when we go to the few cases at the end of the presentation. So now we come to focal lung lesions. So focal lung lesions of GPA actually can mimic everything. And they can mimic metastasis, they can mimic fungal infections, because you see, these have vasculitis. So you can get surrounding, in this patient, surrounding GGO is not there, but you can get halo, you can get reverse halo. So they will look a lot like fungal infections, particularly mucormycosis, but they are bound to, because you see, what is the prototype of an invasive fungal sinusitis or invasive fungal infection, whether sinusitis or pulmonary, is a vasculitis. It's called invasive because depending on where the organ, what the organ is in the lung, once it involves the vessels or the airway, we use the term invasive. When we are in the paranasal sinuses, when fungus involves the vessel or it involves the bone, we use the word invasive. So both of these result in vasculitis. The mechanism is different. Herein it's autoimmune, and over there it is infection. So that is why the closest differential, and of course The treatment for the two is diametrically opposite, because we really have to go in for methylpred pulse or cyclophosphamide the moment the diagnosis of an active GPA is made. So similar to fungal infections, if you think those as prototype, these will, I told you, show halo, reverse halo, these will cavitate. So you will get a lot of thick walled cavities, and you can get pleural effusions. You can also get a picture like these, which is of multiple ground glass nodules. So multiple ground glass nodules, which can look like septic emboli, mostly the differentials being of infections, particularly fungal infections. So what are the manifestations? Which are focal, large nodules, mass-like lesions, which cavitate, which can be subpleural or peribronchovascular, consolidations, ground glass opacities. So we saw diffuse parenchymal manifestations, we saw focal, we now come to the airway involvement. So airway is classified into upper airway, lower airway. Yeah, so, and the lower airway we further classify into central, peripheral, and small. So upper or lower, so in upper we are talking about paranasal sinuses, larynx. Lower airway is basically the intrathoracic airway. In that, the central airway is trachea and the main bronchi. Peripheral airway is the airway all segmental, subsegmental, which shows you all the bronchiectasis. And the third level is the small airway, which is the airway without any cartilage. So what airway gets involved? So in GPA, it's predominantly a large airway involvement. So, and the subglottic larynx is the commonest site of stenosis. You can have the rest of the trachea also getting involved, carina and major bronchi also getting involved, but the characteristic site of involvement is subglottic. And to differentiate it from other causes of wall thickening, every inflammation, whether it is again vasculitis or I keep going back to infections such as tuberculosis, it will be circumferential because it will involve the posterior membrane also, unlike disorders such as polychondritis, which are cartilage related diseases, which will always spare the posterior membrane. And now let's look at one case scenario wherein this is a 39-year-old female who has had bronchial asthma diagnosis only for the past 3 months, established as bronchial asthma, although over the last 1 year, she has been complaining of some level of shortness of breath. She also has a skin rash over the bilateral lower limbs and trunk. She has polyarthralgia and has a saddle nose deformity. You can see multiple ill-defined nodules in both the lungs, and some of these are conglomerate and giving you a consolidation-like appearance. So this history plus this radiograph is enough to give you a diagnosis of a very characteristic diagnosis. We'll go on to the CT to see. So what do we have? We have multiple nodules, some almost the size of masses. They are centered around the bronchi. They don't show much of breakdown in them. Some of them have this very tubular frame-like opacities. You will, in this disease, many times get centrilobular nodules. You will get a lot of bronchial wall thickening. So in combination with the history that I showed, the characteristic diagnosis is Churg-Strauss or EGPA. And basically a elevated level of eosinophils, which you may demonstrate in the serum or demonstrate only in the BAL or biopsy specimens, is characteristic of this vasculitis. So Churg-Strauss is a eosinophil mediated vasculitis, and the characteristic presentation is of the peripheral and small airway involvement. So basically you work up patients who have moderate to severe or poorly controlled asthma showing very high eosinophil levels for this. And obviously when patient is showing very high eosinophilic levels and has poorly controlled asthma, the other close differential for it is ABPA in a setting of asthma. But we have several other things in this patient which points towards an EGPA, because we do have skin rash and we have polyarthralgia, we have upper airway involvement, and the that ABPA also can show a whole lot of overlapping appearances. It's not necessary that you will always get a characteristic finger in glove picture only, but a lot of centrilobular nodules with these larger area of consolidation point towards a diagnosis of EGPA rather than an ABPA. So small airway disease is characteristic of ABPA. It's also a granulomatous inflammation, but eosinophils are the characteristic feature here. Now we did lung, in which we did diffuse and focal. We did the airway, wherein we saw right from the subglottic region up to the peripheral airway, up to the small airway. And now we come to the pulmonary artery. So here also, the presentations are, they may look actually mutually contradictory in that it's a vasculitis. So understandably, you can expect that it can give rise to aneurysms, but it can also give rise to thrombosis. It can also give rise to stenosis. So all these manifestations can occur. This is a patient with GPA who has got a pulmonary embolism. But now we come to the dramatic presentation of vasculitis, which is pulmonary artery aneurysms. So if you look at pulmonary artery pseudoaneurysms and pulmonary artery aneurysms, so this is how we look at the etiologies. Again, the closest differential, all along, which will run with vasculitis would be infections, vasculitis, and other inflammatory lung diseases, tumors, iatrogenic. These are all causes of pulmonary artery aneurysms. So in the vasculitis, there are two entities, the Behçet and the HSS or Hustovin. And pardon me if the pronunciation is like a little different. So now this is a patient of Hustovin disease who gives rise to, large aneurysm, which involve the segmental branches, sometimes go up to the periphery and involve the subsegmental branches also, but these are fairly large, lobar and segmental branches, very difficult to differentiate from mycotic pseudoaneurysms because patients come with fever. And as I said, just like we saw in lung lesions, in pseudoaneurysm and aneurysm situation also, the main differentiating point is this an infection or is this HSS or Behçet we are dealing with? And the endovascular intervention for these is also very challenging because one, they are very multiple, and two, they are involving very proximal part of the tree. The more peripheral the aneurysms are, they are easy for us to treat and embolize. And the more proximal they are, the more difficult they are to treat because we cannot go and close the arteries with impunity. So you would have to employ stents, etc. many times. Now, when you see aneurysms, first you have to take a call whether mycotic or these are non-mycotic. Once you decide these are not mycotic, then we have to differentiate between HSS and Behçet disease. If you look at the differentiating features, both of these can be associated with aneurysms, but the aneurysms are far more common in HSS. Thrombophlebitis can happen in both, but the main differentiating points are oral and genital ulcers and the pathology test, which is actually a diagnostic criteria for Behçet. So when this is not present, it becomes an HSS. That is how our previous question was also labeled as HSS, because we started by saying that it can be a BD, but patient has no oral or mucosal ulcers, patient's pathology test returned negative, and there was no eye involvement. The likelihood that you are dealing with this becomes much more. If you see the multi-system manifestation in HSS are less, except for neurological manifestations which happen in both. Pleural complications, we already saw that there's pleural effusion, and of course in GPA mainly all these cavitating nodules can keep rupturing and have all the complications which are associated with cavitating nodules of any etiology, whether they are septic emboli or they are metastasis. So they will be a cause of recurrent spontaneous pneumothoracis. They can result in pyothorax. So the associated complications of cavitating nodules, like in this patient, you can see an ICD is in C2, but the pneumothorax is gloriously unaffected. And that is due to presence of a bronchopleural fistula. So as I said, basically all the attendant problems which come with dealing with the lesions which rupture into the pleura are very frequent in a setting of GPA. Now let's summarize and try to differentiate amongst the various types. So to reiterate, we discussed ANCA-associated vasculitis as three entities: MPA, GPA, EGPA. And what we saw so far, we saw very distinct features between GPA and EGPA. Immune complex, I told you that good pasture or anti-GBM is the prototype. And these are the other immune complex deposition diseases such as IgA-associated or cryoglobulinemic. Now, let me just show you the main differentiating points between GPA and MPA. So we did do the type of ANCA in both is different, yeah, whether it's PR3 or MPO, we did that. But the clinical manifestations and the type of pulmonary involvement, which you will see on imaging, is also different. So you see the paranasal sinus involvement and the otitis media manifestations are far more common in GPA, but far less in MPA. On the other hand, in the lung, nodules, cavitating lesions are more common in GPA, whereas MPA, the prototype is pulmonary hemorrhage, and recurrent pulmonary hemorrhage results in an ILD also, which is seen in MPA more frequently. So this is a characteristic difference between the two. Let us look at an example: 33-year-old female who has history of spontaneously teeth falling out. If I did one session, I think for the ICRI on head and neck osteomyelitis, and talked of this symptom of teeth falling out. And it was a symptom that we faced a lot during COVID because of COVID-associated mucormycosis. But mostly, most of these lesions which cause necrosis of the jawbone are not infections. It's aseptic necrosis, which is very common, and vasculitis is an important cause of aseptic necrosis. And the characteristic symptom is this, that people just start to lose their teeth and that whole jaw becomes mobile, as if the whole maxilla is moving. And in GPA, the other causes of lesions which cause destruction like this include sarcoidosis and fungal infections. Rhinosporidiosis, rhinoscleroma, those are the things we differentiated from. What is characteristic in GPA is that the inflammation starts from the inferior turbinate and spreads laterally to involve the maxillary sinus, gives this very layered kind of appearance of the involvement of the anterior wall of the maxillary sinus, which is very typical of GPA. Just one sec, again this, yeah. Okay, so this is the bone window of the same. So it's almost like you get sequestrum, this layered, it's called a serpiginous appearance, and you see it very characteristically if you perform an MR on T1 weighted images also. And osseous erosions, I already explained to you the differentiation. One typical feature which divides sarcoid versus GPA is that the palate is involved far more commonly in GPA. So this was our diagnosis, obviously based on other multi-system involvement and returning of the ANCA. This is another patient, she's 42 years, she has a lung lesion, she has some what looks like a chronic rhinosinusitis with or without bone destruction, not as dramatic as the previous patient we saw. This was in 2016. Patient was diagnosed and treated as a GPA, this is 2016, and after 6 months of therapy and subsequently returned to us with increasing dyspnea, cough, and chest pain. What I wanted to show you was that what it looked like an innocent CRS is in this, which is that all the septum are destroyed and you get atrophic rhinitis and all the problems which come with atrophic rhinitis, basically a immense amount of crusting and a foul smell which comes associated with this disease, and this is what GPA results in if it is not controlled in time. This is a patient of microscopic polyangiitis on the other hand, who tend to have recurrent pulmonary hemorrhages as the main manifestations. And many times the CT will look just like this, that because of the superimposed subtle fibrosis, you will just get this mosaic attenuation type picture or a subtle thickening. So as you can see that disease-wise, it comes in the same category as a GPA, but it looks very different as far as lung imaging is concerned. Now, this is another, prototype clinical situation which comes very frequently. So this age is characteristic, the appearance is characteristic. 19-year-old male, as we go and see the disease as it involves, one of the few diseases, amongst all the autoimmune disorders, some disorders only tend to involve the male population, and some of them, involve more. Otherwise, like majority of the autoimmune disorders involve the women more. So patient has a rapidly progressing renal failure. He's 19-year-old and his chest radiograph looks like this. So what is your clinical diagnosis based on this history? This history alone, this suggests an RPGN, this suggests a DAH. So your clinical diagnosis is a pulmorenal syndrome. So this much information is enough to make a diagnosis of pulmorenal syndrome. And then we will go on to see, what are the types of pulmorenal syndromes. So basically, we will same back all vasculitis, ANCA positive or ANCA negative. In this patient, the ANCA is negative. The renal biopsy returns basically a glomerular disease, so proliferative glomerulonephritis. And this we already did, that relative sparing of the extreme basis. So they can be in a epicobasal gradient, but extreme CP angles, epices of the lung may be spared. So two scan mean one, the animation. This is the first scan, which is of 5th December. Okay, so patient has 2 scans. This is the first scan of 1st December based on history, which was reported as a diffuse alveolar hemorrhage. And if you look at the second scan, which is on 20th December, where patient has already been started on immune suppression, see how fast it has resulted in some level of fibrosis, septal thickening, and actually a picture of cystic lung disease. So this is what it looked like in an intervening period of 2 weeks after patient had been immune suppressed. So this was anti-IgM disease, or previously called good pasture syndrome. So let us look at pulmonary imaging of various vasculitis. We'll just reinforce GPA, pulmonary nodules, subpleural, peribronchovascular, major airway involvement, central airways. And in the peripheral, you can get ground glass nodules, centrilobular nodules, MPA, mainly DAH, and interstitial fibrosis. EGPA, airway disease with eosinophilia. Anti-GBM disease, pulmorenal syndrome. So the 4 types of common SVBs picture. So these are known as pulmorenal syndromes. Basically, in pulmorenal syndromes, also when you suspect the pulmorenal syndromes, you first rule out infection, structural region, CCF, and then it comes down to whether something is ANCA associated or anti-GBM associated. If your lung picture is or is not consistent with DAH, and a simple urine dipstick, whether it is showing blood and protein. So combination of these 2 and will give you a diagnosis of pulmorenal syndrome, and then you proceed to see whether that it is ANCA associated or anti-GBM antibody associated, and then which type of ANCA. And a BAL is required for definitive diagnosis of DH, but is obviously not done in all patients and not indicated if clinically and serology wise the picture is matching. Now we finished with small vessel vasculitis. We come to large, medium, and variable vessel vasculitis. So large vessel is 2 entities to remember: Takayasu's and giant cell. Medium vessel, basically Pan, Bechet, Kawasaki, and variable Bechet can actually fall into both categories. So this is a patient of Takayasu's arthritis. As you can see, the characteristic involvement of the descending thoracic aorta. Young patient, the entire DTA is narrowed. You can have subclavian also narrowed. Sorry. Yeah. And so look at the narrowing of the DTA on the axial images, the wall thickening, and then patient has DAH. So usually capillaritis is not a component of Takayasu because it's basically a large vessel disease, but you can get involvement of smaller vessels also, and patients can present with DAH. It can also cause pulmonary artery narrowing and stenosis, as you know. Now, if we look at the large and variable vessel diseases, so in Takayasu arthritis, what are the pulmonary manifestations? You can get pulmonary artery aneurysms, you can get stenosis, you can get pulmonary hypertension. Same in giant cell arthritis, you can get thrombosis. Behcet we already saw. Tan, you are familiar that it gives rise to basically visceral aneurysms. Occasionally, you'll get bronchial aneurysms also. And in sarcoid, again, you can get nodules and mass like GPA because it is associated with the necrotizing type of granulomatosis. So even in the large and variable vessel, there are characteristic findings. Basically, I will come to a morphological DD also subsequently, that if you see aneurysm, what do you investigate for? Like we discussed, if you see DH, what do you investigate for? Last category is this vasculitis associated with systemic diseases, mostly CTDs, and this has everything: infections, drugs. Let's see a case. This is a 14-year-old child and who has SLE. And so adolescents, most of the, unlike younger children, most of the DLDs in adolescents are basically autoimmune mediated, and that's why you have a lot more girls presenting with DLDs in this age group. So the dates are marked here: 12th of January, 15th of January, 12, 13, 15, 24. So patient had these diffuse airspace opacities which get denser, and then around 24 Jan, they tend to clear out. But subsequently, this patient worsens, and when we do the CT, you get a distribution like an ARDS, which means that there is a distinct apicobasal, plus there is a distinct dorsoventral gradient. But is it like a typical ARDS? So not really, because typical ARDS should not have had this asymmetric large area of consolidation. So we are not able to give a clean sheet and be clear that whether the patient has superadded infection or not, because patient has been immune suppressed for the SLE. And in this situation, what are the all combination of findings that are happening? So just to clarify so that there's no confusion, this is a 14-year-old child with DAH. This is a second patient of SLE, different patient who came with an ARDS-like picture, which when you see an ARDS-like picture, you classify on CT as typical or atypical. So we classified it as atypical. Typical ARDS means that the cause of the ARDS is outside the lung. Atypical ARDS means the cause of the ARDS is inside the lung. And the most common cause is infection. So patient has SLE. We are having to take a call that whether patient can go for methylpred pulses or not. Is this clear for infection? And we say that this is not clear for infection. But eventually, this patient is proven to be what? I will show you subsequently. I have this case in full detail. Now I come to the morphology-based approach. We discussed about different entities. Now we come to morphology-based approach. So if you have a pulmonary artery aneurysm, I told you, and first thing is you rule out mycotic aneurysms. If you rule out mycotic aneurysms, you are looking for two disease entity, Behcet disease or HSS. Okay. If we have large vessel involvement of aorta, pulmonary artery with stenosis or wall thickening, if patient is young, less than 40 years, we are looking for at Takayasus. If patient is older, more than 50 years, we are looking at giant cell arthritis. If we have a situation where we have nodules or masses or DH, we are looking at ANCA, whether it is positive or negative. If ANCA is positive, we are looking at MPO or PR3 predominance, and then we have already discussed how we go on to classify it. If it's negative, then again we are looking for immune complexes. If they are present, we are labeling it as anti-GBM disease. If we have patients with an airway kind of COPD, emphysema, asthma. So in asthma, we saw that we are looking basically for EGPA, and these are the lesser known causes of immune complex deposition diseases, which can be associated with COPD or emphysema. I tried to research, that how much was COVID-19 and pulmonary vasculitis actually, was it really vasculitis? So even on testing MIS, looking at articles of multisystem MISC in children, so there are very few articles which actually report that there is an eosinophilic inflammation of the pulmonary vasculature causing vasculitis, and some which says that with the Moderna vaccine, ANCA-associated vasculitis, including pulmorenal syndromes, get precipitated. But otherwise, what we had in COVID was a vasculopathy, but which is not strictly classified as a vasculitis. So myriad of presentation, and you have to really have your antenna up and have a very high index of suspicion, and infection and disease activity look clinically so much similar and look imaging wise so much similar that it's a challenge to differentiate. So let's just quickly see some cases. 11-year-old child who you'll see from the clinical presentations, who comes with fever, weight loss, and vague aches and pains for 1.5 years, maybe some fissural thickening here. And apart from that, can't make out much on the chest radiograph. Similarly, when you look at the CT, what do you get? Fissural thickening. This fissure is thickened, this fissure is thickened, some subpleural band, some pleural thickening, which almost looks like atelectasis. But this atelectasis or fissural thickening is also characteristic of a form of vasculitis. It's a lesser known presentation, but it's a form of vasculitis. So further history reveals, and how obviously it's a multi-system disorder, you need other things to help you make the diagnosis. Patient has arthralgia, myalgia, ulcers, painful swelling over the limbs, which are this is the ultrasound that we did, which shows wall thickening of the vessel, but also shows a lot of soft tissue around it. And patient also has anterior chamber cells. Patient has very low hemoglobin, but there is no renal involvement. Initial ANA, ANCA, everything returns normal. But patient has a positive HLA-B5, which means that this is a Behçet disease. So from the skin nodule, a biopsy is performed. We perform a biopsy from that thickening that I showed you, CT guided, and it shows us a clear-cut vasculitis, and there's a chronic inflammation, and all the walls of the alveoli as well as of the vessels are thickened and have inflammatory cells. So what is this manifestation of Behçet, which we should have picked up on the CT? So these were the multi-system involvement in this patient, which led to the diagnosis. But this is an interesting article on the thoracic manifestations of Behçet disease, and what exactly does this represent? The atelectasis that we saw, what does it represent? So what happens is that there is vasculitis and thrombosis of the peripheral vessels, which result in small infarctions. And so what you get are these peripheral areas of infarction, something which looks like atelectasis, something which looks like pleural thickening. But in a patient who has other manifestations that this may be vasculitis, this is a picture that comes in Behçet disease. And we also got this diagnosis from, like similar to this patient, we also had this sliver of paravertebral soft tissue from which we took the biopsy. Now, this is case 2, 49-year-old male, and nasal polypectomy, now coming with fever, weight loss. So something in the upper airway, something in the multi-system. So upper airway also immediately alerts you to vasculitis. Eventually, the patient was proven to be GPA with C ANCA positivity. There were multiple nodules which cavitated. This was in March 2017. Patient received cyclophosphamide pulse therapy and improves. And what happens when the patient improves? This is March we saw, then June, and then August. So these become, thin-walled over a period of time, and they develop air fluid levels. So we are puzzled that is this, part of active disease or is this part of infection? So this is what it looked like initially, thick walls and with these, small nodules hanging from the wall, and eventually a very thin-walled cyst, but which have increased in size and have large air fluid levels. So after, again, the call is always how much to go with the immune suppression, whether to stop it or not. Eventually a Bhalla is required, which revealed Pseudomonas, and basically the entire air fluid level was a part of the secondary infection. So patient in fact grew two organisms, Aspergillus fumigatus also and Pseudomonas. So secondary infection in these cavities is common. And this is another 23-year-old male patient with similar. Most of these patients, when we look at them, will have like so much imaging to compare and such a long story, which each time we have to see that how immune suppressed the patient was when the new manifestation came to take a call on infection versus disease activity. So this one also, December, patient is diagnosed, has consolidation, thick-walled cavities. This is January of 2019. And eventually, patient continues to have these very thick-walled cavities with this nodule hanging. Again, we are asked to take a call that this is an air fluid level developed on treatment. Is it active disease? Is it infection? And in fact, this one underwent a biopsy and it showed no infection. So it showed everything as a part of granulomatous vasculitis. So this is a difficult call. And as I said, you go with serial imaging. You need to know the status of the ANCA at that time point and status of the disease activity elsewhere. But despite all this, a lot of decisions are left to the radiologist to take a call, and several of these sick patients are not fit for Bhalla also. This is a 51-year-old male who's a smoker who comes with streaky hemoptysis, plus some systemic symptoms, plus a past history of dactyloadenitis, and now practically everybody has a past history of COVID, which is compounding. On investigation, he's found to have leukocytosis. There's a right upper lobe nodule which is detected, and patient is a smoker, although the smoking index is low, and he has come with hemoptysis. The right upper lobe nodule is labeled as a carcinoma lung with a dissemination with mediastinal nodes and sent to us for biopsy. We are very reluctant to do the biopsy, which invites a lot of wrath, but I'll tell you why. So this is what the diagnosis is. This is a carcinoma lung, and this is the nodes. But when we look at this CT, something about this does not look like a malignancy. What does not look like a malignancy? You see this very, just like you see in Crohn's disease, in the abdomen and bowel, as a very mural kind of stratification. You're getting a very similar appearance here, a very mural kind of stratification. And what I noticed is that if I'm looking at the aorta also, for instance, this is not, a partial volume averaging. There is something wrong. The wall of the aorta is not clean. The wall of the aorta is not clean. And then when we look down, there is some pericardial thickening also. So I dug my heels on this one and I said, no, I'm not going to biopsy the right upper lobe nodule because it's not going to give me the answer. You go in for an ANCA, and if required, go in for a diagnose, EBUS guided biopsy from this paratracheal thickening, and this should give us the answer. So as I told you, in the infection versus malignancy, the main thing was the stratified appearance, the periaortitis, the pericarditis, no effusion, but pericarditis, which gave me a look of an inflammation. If there's a look of an inflammation, I could not think of any infection which can do this, although tuberculosis would be a close differential. Then in this whole argument went up back and forth that you are trying to avoid a biopsy, and why on earth should we try to avoid a biopsy? We like to do biopsies, but we asked for a PET CT. PET CT showed some areas are very PET avid, but this right upper lobe nodule ain't PET avid. It does not pick up any FDG. And so eventually we look at the PET CT and it gives us a slight mucosal thickening here. But still the diagnosis that we suggest is that we can be dealing with a GPA, we can be dealing with IgG4 related disease, or we could be dealing with an infection such as aspergillosis. And the patient returned C. Anka positive, serum galactomannan negative, IgG4 levels were also normal, and the final diagnosis was a GPA, and he responded so well to the steroids, followed by patient received rituximab also. And everybody had labeled him as a malignancy with a dissemination, and he was very happy and gave a very nice gift to our thoracic fellow, because at least he got a diagnosis. It's not a good disease to have, but while it's steroid responsive and responds to your initial first line drugs, it is controllable. So the classic triad of GPA is upper airway involvement, lower respiratory tract involvement, and glomerulonephritis. These are the ACR criteria, most of which we have discussed. And we have mostly discussed the pulmonary manifestations. But what I want to point out is that there's a lot of the heart and pericardium which we can report on all non-gated scans, and we need to, they are repeated, so many articles in radiographics reviews, so many pictorial reviews come out on how much of cardiac can you report on non-gated scans, and actually the answer is a lot. So the answer to us came from the pericarditis, the iotitis and periiotitis. Periiotitis is a very characteristic manifestation of IgG4 related disease also. So that's why we gave it as a differential. Shivani, you can tell me when to stop if I'm exceeding my time. I think I have a couple of cases left. So another 64-year-old male, similar kind of story always. Fever, dysuria, being treated as UTI. Patient continues to have persistent fever for reason. Then he's brought here, pus cells, RBCs, deteriorating renal functions, rapidly progressing renal failure, and a sudden onset shortness of breath where the SpO2 drops to 78%. And this is the picture we get. So DAH versus an atypical infection that you could be dealing with the viral pneumonia. And if you make none of those two diagnoses, if it doesn't turn out to be a DH or doesn't turn out to be pneumonia, then the third is that you label it as an idiopathic acute interstitial pneumonia. Those were the DDs, but remember we have other manifestations. We have an RPRF, which is rapidly progressive renal failure. We have precentric glomerular nephritis, which is P. Anka positive, and it was an Anka associated vasculitis, which was labeled as MPA. We already saw that MPA tends to have a diffuse lung involvement, unlike GPA, which tends to have more of focal lesions. Then patient received standard first line immune suppression, etc., and is treated. And a lot of this resolves, but a lot of, you can see that you get an UIP kind of picture, but some interstitial changes remain. But what is the problem, which I've showed you in several cases, is the infection which starts to come in. So a new area of consolidation starts to develop, which obviously the patient has been immune suppressed. So we raise the possibility of bacteria versus fungus basically. And eventually this fibrosis also progresses very fast. Because of the increasing ventilatory requirements, you can see patient is getting positive pressure ventilation, develops air leaks. This area goes on increasing, now has a very mucor-like look and is found to have aseptate hyphae. And although we made the correct diagnosis and treated it by the book, we lost this patient to septic shock. So because of the level of immune suppression that is required to be used, infection is a very big problem in all these patients. This is the lady of SLE, which I was showing you. Actually, this lady had come to us as a seropositive RA who had been on methotrexate and HCQS for 3 years, but now developed shortness of breath with hemoptysis and had a falling hemoglobin, very high level of TLC, ANA positive, SSA positive, and echogenic small kidneys, and Bhalla basically gave nothing. And we already discussed the CT, and I told you that we were like, is this infection? And so patient was getting some level of steroids, but the methylpred pulses were being held back because infection was a very likely possibility. In the end, we were like pushed to the, with our backs to the wall. We decided to do a thin needle biopsy with a 20 gauge, and we took a specimen from here. And although the patient did through a bout of hemoptysis, but we were doing it in the ICU in a ventilated patient. And finally, when the biopsy report came, it came as DAH with extensive hemorrhage and no infection. And the final diagnosis was lupus pneumonitis. And the patient did get pulses, and we eventually lost the patient. But why I brought this is that, by now I've learned to recognize that picture of lupus pneumonitis. It's a unusual manifestation of SLE also, but this very, very uniform kind of consolidation that we were getting in the dependent lung is very unlikely because of an infection. Although, as I told you, that right upper lobe area was what was making us apprehensive. And eventually our final diagnosis was SLE-RA overlap with CKD and lupus pneumonitis. So see, this patient does not have glomerular disease, did not come with a anti-GBM disease, good pasture type of patient, already had a CKD, but patient had a SLE-RA overlap, and final diagnosis was lupus pneumonitis. Another patient that we lost, these multifocal consolidations, simulate infection and ARDS. So this lupus pneumonitis also needs a very immediate aggressive immune suppression, and another difficult call to take. This is the last patient whom is currently with us. He's a 20-year-old child who has been a CKD patient for the last year and a half on maintenance hemodialysis, who got fever for last 2 months and sore throat and developed shortness of breath. He's a syndromic child who has associated skeletal dysplasia. And again, when we did the CT, the topogram showed a picture which was suggestive of a DH. And when we did the CT, it was suggestive of a DH, but we were stuck as to the cause of DH. Okay, the kidney is not helping us. We have no skin lesions. And apart from ANCA, for active autoimmune disease, we place a lot of reliance on C3, C4 levels. So patients' C3 levels, complement levels did return very low, although C4 levels were normal, but we did not have any ANCA positivity, and we were really stuck as to what, and he was throwing DAH and hemoptysis like by the hour. So, and we were not able to adequately immune suppress. I'll tell you why. So this is again characteristic. I told you, sparing of the episis, sparing of the CP angles, and the lobular appearance, so that we were sure that we are dealing with DH. The issue was that what is the reason for the DH? And I told you that you can have bland DH or you can have capillaritis associated DH. The up-to-date gives a whole lot of causes of what can, so of capillaritis associated, of bland hemorrhage, of DH associated with hyaline membranes. So all these, whatever we could work up on serum levels, which means ANCA, immune complex, C3, C4, everything we were sending for, but I'll come to the findings. Again, on a non-gated CT, we didn't pick up these findings. The findings came from the echo, but if you see in hindsight, you will be able to see the findings. So what was there was that there are, if you look at the aortic valve, this is very thickened. And, similarly, if you see near the papillary muscles also, you can see some filling defect. Near the interventricular septum also, there was thickening. And if patient had small infarcts in the spleen, so basically patient had developed infective endocarditis consequent to the central catheter, which had been placed for, you saw a catheter in the jugular, which this is the tip of that catheter at the sinoatrial junction, which had been placed for the dialysis, and the infective endocarditis itself resulted in the DAH. So, this is the criteria which are used for diagnosis of infective endocarditis, the modified Duke's criteria. And based on these, we labeled it as a infective endocarditis. And eventually, this was a IE associated DH. A lot of infections can result in DH is what I wanted to bring out. So you can predict the organism based on whether your patient is immune compromised or immune suppressed. So in immune compromised patient, you can have opportunistic organisms, CMV, adenovirus, aspergillus. In immune competent patients also, influenza itself, leptospira, dengue are the common ones which we have encountered, which can result in diffuse alveolar hemorrhage. This patient also, we have even given plasmapheresis, but looks like it's an uphill task and we will not be able to save because he's continuously bleeding despite all efforts. So, as I told you, everything is returning negative except that they are very low C3 levels because the methylpred could not be given because of patient was in sepsis. And so plasmapheresis was given, but he has worsening ongoing hemoptysis. So vasculitis is a very challenging topic, but the thing is that, as I showed you, in the Behçet disease, which was atelectasis in the right upper lobe nodule, and in several other situations, it's the radiologist antenna which first points to the diagnosis. So the first role is, diagnosing the atypical vasculitis, and then throughout their treatment, you are like hand in hand with the treating team, because there are a lot of complications which are going to come in the lung, and you are going to be a part of that MDT, helping them take an infection versus immune suppression, basically grading the response throughout the course of this illness. And thank you very much. And a disease of young people.
Thanks a lot, Dr. Ashu. That was extremely informative, and there was a lot of good information that you shared with us. And the best part was that there was a follow-up available. So all this is really substantiated, and we know that whatever we are hearing is actually what you have seen in clinical practice. So that was an excellent talk, and we thank